So I'm very excited and pleased to be sharing with you today some of the evidence around treating and managing cancer-related fatigue. It's something that at some point in their journey, every cancer patient experiences, and it's one of very distressing issues. Okay, this is just my disclosures, which basically consists of sources of funding for my research. So as I said, fatigue can be a very common and distressing symptom that can occur from the moment that cancer is diagnosed and persists during and after cancer treatment is completed. And studies demonstrate that at some point, up to 100% of patients express problems with fatigue. And one of the issues that actually Dr. Barrera made me think about this morning is that fatigue is something that we can all relate to. It's a term, we've probably all felt fatigue at one point in our lives. And it almost does a bit of a disservice to what this symptom actually is for patients, because it truly is not the kind of fatigue that any of us have experienced in our lifetimes. And in fact, what patients share with me is they can't believe how they feel, that they have nothing to compare it to, that it's such a different and unusual experience. To the point that sometimes they tell me that when they're sitting down and they have to go to the restroom or they want to get a drink of water, the thought of getting up out of the chair and walking across the room is almost overwhelming to think about. And so when we talk to patients about fatigue, keeping that definition in mind, you know, we kind of glibly say, yeah, cancer-related fatigue is a kind of fatigue that isn't relieved by rest, or isn't commensurate with the kind of activity that we do. So we can have we can go to bed and just feel the exact same way as we do in the morning. And I think that level of fatigue is very frustrating and extremely consuming to patients. So a lot of people also think about cancer-related fatigue as, oh, well, that's related to chemotherapy or radiation. But the longitudinal descriptive studies that are being done show us that up to a quarter of patients, even before they start any cancer treatment, can report severe fatigue. And that fatigue after treatment is over may not ever return to baseline. And for some people, it extends for many, many years after treatment is long completed. And the longitudinal studies we have right now are out about 10 years. So there have been 4 prominent organizations that have either revised or developed their cancer fatigue management guidelines just in the past 2 years, which just shows you, I think, how much research is being done in this area. So there's 2 here. The National Comprehensive Cancer Network and Oncology Nursing Society. And what I want you to notice from this guideline, so this column are things that are considered effective, have high evidence, lower evidence, just need a little bit more information probably, and then things that are either not effective or we have no data to support them. And you can see that there's a little bit of a difference with the NCCN suggesting that several things are helpful, and the Oncology Nursing Society suggesting just exercise having evidence for clinical practice at this stage. And a lot of this is obviously related to how these organizations define what is sufficient evidence for clinical practice in their guidelines. But you can see that at least there's some overlap in terms of cognitive behavioral therapy, psychoeducational, supportive expressive therapies having potential. This is 2 other guidelines. The American Society of Clinical Oncology, who just published a guideline in 2014, and the Pan-Canadian group updated theirs in 2015. And the disparity I want to point out here is the American Society of Clinical Oncology still saying psychostimulants in advanced disease and during active treatment have some value, and the Canadian group saying, I didn't explicitly write it out here, but they say there are no data to support the use of psychostimulants in fatigue. So what I want to do today is kind of go over some of these modalities and the evidence that we have for them, so that when you're looking at these myriad of guidelines, how do you decide what really is worthwhile to do with your patients with the difference of opinion? And so what I'm hoping to do is give you some evidence for some of the things that I think are more promising, and do it in the lens of mechanism, because I'm going to talk a little bit about what's holding us back with being able to really find some effective things to even prevent and manage fatigue in a broad way. So based on the evidence available, it's my opinion that the strongest role for pharmacologic agents in controlling fatigue is in controlling the comorbidities that can add to that. And so things like pain, hypothyroidism, anemia, and cardiac and pulmonary issues are some of these things that there are medications for, keeping in mind that particularly for the cardiac drugs, the side effects of those can actually add to the whole fatigue burden. So despite the popularity clinically and the ASCO guidelines, I would like to point out that a vast majority of the placebo-controlled randomized trials with psychostimulants, whether they be methylphenidate, modafinil, or armodafinil, have been decidedly negative. One exception to this may be in patients with brain tumors. There's pilot level data saying that there might be some role for psychostimulants in those patients, and in a minute you'll see why that might be. Based on work done at MD Anderson, Dr. Barrera's group, there may also be a role for using a short course of steroids in patients with advanced disease. This slide actually summarizes two studies, one with dexamethasone, one with methylprednisone, both done in populations of advanced cancer, short time frame, 2 weeks, but both showing an improvement in fatigue. And importantly, the study that was done with dexamethasone showed that the improvement in fatigue was not mood mediated. So one might think, oh, steroids kind of give you that high, and maybe it's because you just feel better that you think your fatigue is better. But in actuality, that study looked at emotional role and some psychological effects, and it was not helpful and did not mediate the improvement in fatigue. So again, with steroids, you have to weigh, of course, the risks and benefits in terms of the side effects. And I think what's clear from the work done by this group is that a short course of steroids in an advanced population may have more benefit than harm. So one thing, as I said, that's limited the ability to identify truly effective treatments for fatigue is a lack of knowledge about the physiology. And right now there's two leading hypotheses regarding fatigue that have been mostly done in cross-sectional descriptive studies. There have been some longitudinal studies, but very few. And most of this research has been done in women with breast cancer, which I think is very problematic because, as you know, one of the goals of breast cancer treatment is to deplete hormones. And I think that whole issue of hormone depletion very much confounds the issue of what's actually going on with fatigue physiologically. But the current hypotheses are that cancer-related fatigue is associated with increases in pro-inflammatory cytokines, and even to the point of some studies showing genetic upregulation of inflammatory pathways. And then secondly, that fatigue is associated with the inability of the hypothalamic pituitary adrenal axis to mount a strong response to inflammation. Now generally we have inflammation episodes going on all the time, but our body knows how to regulate that, so our HPA kicks in, our inflammation goes down. But for some reason in people with chronic fatigue, that balance, it does not no longer exist. Now the issue is that we don't actually know how these two things are linked in cancer-related fatigue, and we actually don't know what's truly causative. So it's not surprising then, based on those two hypotheses, that the studies in psychostimulants haven't turned out to be positive, because they actually work by promoting wakefulness via various neurotransmitters such as histamine, norepinephrine, and dopamine. and even orexin, and these things have not yet been associated with cancer-related fatigue, either in a correlative or a causative way. But it's why they may be helpful in brain cancer, because it is the fact that they work through cortical neurotransmitters that may be more mechanistically relevant in brain tumor patients than patients without brain tumors. But again, more research in that area needs to occur. However, steroids are potent anti-inflammatories, and so if it is indeed true that inflammation is a causative factor in fatigue, it makes sense that the steroids are helpful for cancer-related fatigue. So it all fits. And when you see, I think, limited research and some differences in opinion in research or findings in research, it helps to kind of put that mechanistic lens on it, because it gives some context, and you can say, well, it would make sense that this would be helpful because of what we know about, or what we think we know about the mechanism of fatigue. Whereas this set of data is very mixed, and it doesn't fit with the mechanism of fatigue, so you can sort of set that aside more easily. So ginseng is an herb that I've been interested in for some time, and one that also potentially fits the physiology of fatigue. It's a perennial plant. It's a popular component of traditional Chinese medicine. It requires about 4 years of growth to be potent, and there have been active constituents identified called ginsenosides. There have been, in fact, over 100 different ginsenosides identified from various parts of the plant: the leaves, stems, flower heads, root. And these ginsenosides in both in vitro and animal experiments have shown biologic activity. Specifically, in vitro studies with a breast cancer cell line have showed that water extracted Wisconsin ginseng inhibited cell proliferation by inhibiting the MAP kinase pathway, which is an inflammatory pathway. Another recent study evaluating the effect of American ginseng on lipopolysaccharide-induced depression demonstrated both decreased hypothalamic pituitary adrenal activation and decreased pro-inflammatory cytokines with ginseng compared to saline. And finally, investigators tested various components of ginseng in Sprague Dawley rats for effects on running time when the animals were exercised at 70% of their VO2 max, so they were exercised in a very stressful way, and found that ginseng given over 4 days significantly improved exercise time. And they did something very cool, in my opinion, to get at mechanisms, is they took different ginsenosides away and put them back to see what was possibly an active component. And when the ginseng compound had neither RB1 or RG1, it didn't work. But when either one of those were present, the rats exercised more. And interestingly, American and Asian ginseng have a good amount of RB1 and RG1. We looked at American ginseng and did a dose-finding pilot study, which then led to this study where we randomized 364 people to receive 2,000 milligrams of Wisconsin ginseng versus a placebo. The ginseng was a pure ground root in a capsule, and people took 1,000 milligrams at breakfast and 1,000 milligrams at noon. And it was standardized to a 3% ginsenoside content, which was not as much as we wanted. Eligibility criteria were patients needed to have a fatigue level of at least 4 on a 0 to 10-point scale. It had to exist for at least a month, and they had to be treated with curative intent. Other causes of fatigue had to be ruled out. Patients couldn't be on chronic steroids, opioids, or have active infections for obvious reasons. They couldn't start or stop anti-cancer therapy, so we allowed patients who were getting anti-cancer therapy to join, but also people who had finished their treatment, but they just couldn't be transitioning one to the other during the course of the study. And then we also excluded dietary supplements for fatigue. We used the Multidimensional Fatigue Symptom Inventory, which asked for very physical type of fatigue questions. Are you pooped? How pooped? Worn out? Fatigued? Sluggish? Do you feel? We also looked at side effects and some other fatigue measures just to look at the robustness of any potential outcomes. And we looked at change from baseline at 4 weeks to 8 weeks and 8 weeks. Based on our pilot study, we thought that 4 weeks would already show significance. And we did stratify by those on current treatment, baseline fatigue, days of prior treatment, and then tumor type. So just our consort diagram, we had about 170 patients in each arm start the study, and about 150 had data for the primary endpoint. Patient demographics included that patients were 55 years of age. They were mostly white, or mostly female, and mostly white non-Hispanics, and about half were postmenopausal. There were no differences with regard to disease characteristics, and the sample was equally split with regard to time since diagnosis, and also just over half the sample had breast cancer. Treatment characteristics were also not different. About half were getting, therapy, about half had had 6 months or more of therapy, and hardly any were on endocrine therapy, which was a bit of a surprise to us. So these were our findings. At 4 weeks, there was a trend toward better fatigue in the ginseng group, but it was not statistically significant until 8 weeks. And the difference in fatigue scores on when our statisticians moved to a 100-point scale was a change of 20 points in the ginseng arm versus 10 in the placebo arm. This is just to show you that physical fatigue was another subscale of that fatigue scale, and it was significantly improved, but things like mental, emotional fatigue, and vigor were not impacted. So this really helped more of a physical general fatigue. Our profile of mood states fatigue inertia subscale was exactly the same pattern, and so it gave us a lot of confidence in our results. We did look at group analyses. So as I said, we allowed people who were getting treatment on study and those who had finished treatment, and we wanted to see if there was a difference in response. And so here, this is the group that was on anti-cancer therapy, and already at 4 weeks, they were getting a significant improvement in their fatigue scores, where that was not the case in people who were done with cancer treatment. And that people on cancer treatment that continued at 8 weeks and was even a little bit better, and a trend towards fatigue improvement in those who were off of cancer treatment. Now we have some hypotheses about why the people that were off cancer treatment didn't get as much of a benefit, and we don't have any proof of this, but it really makes sense to me in that a lot of people wanted to get on the study. And if they were close to the end of their treatment, they couldn't, because then they'd be transitioning off anti-cancer treatment during the course of the study. So I think what happened was that they actually joined the study soon after they finished treatment. And so in the placebo group, we actually got quite a bit of placebo response because people were getting that natural some improvement in their fatigue once they stopped cancer treatment. So what about side effects? So we asked patients to rate their side effects on a 0 to 10-point scale, and then this was converted to a 100-point scale. So everything above the 0 line is things that got better during the course of the study, and things below the 0 are things that got worse. And only one thing got worse during the course of the study, and that was loose stools at 4 weeks, and it was actually seen in the placebo arm. So there, at least from the patient perspective, there weren't toxicities, and also from the provider rated toxicity grades, there were also no differences between arms. So what we learned was that I do believe that ginseng has promise as an herb for cancer-related fatigue, and I know that thankfully other people are doing work with both American and Asian ginseng. Dr. Barrera's group is looking at Asian ginseng, and I think we need to understand the mechanism, and we need to understand more broadly how ginseng might fit into the treatment of cancer-related fatigue. I do have some very exploratory preliminary data that would suggest it's working through the metabolic pathway, and I'm getting ready to send that in for publication. So physical fatigue was impacted, but not emotional or cognitive. And the potency issue, I think, is important. And I will just say that I am very much aware that herbs and dietary supplements not being FDA-approved drugs and not being synthetic agents, that there's a lot of variation just agriculturally in what can be going on with these plants. And that is important to understand, and is definitely a limitation of not only studying this area, but also having it available for patients. And so it is important that I think that we understand the agents that we're studying and where patients can get them, which is part of the reason why I used Wisconsin ginseng, because it is a known entity that is obtainable. So now I want to turn to some behavioral approaches for fatigue, and first talk a bit about physical activity. The one thing that you might remember is that every single guideline listed physical activity as being effective. And there indeed have been numerous meta-analyses of studies evaluating physical activity in some form that represent well over 4,000 patients and over 60 studies. So there is a robust group of data in this area. Unfortunately, the effect size is moderate at best in most of these studies. The studies have used various types of people with cancer, looked at both aerobic and resistance exercise, both during and after treatment. And the good news is that all of those studies are pretty much consistent that it all works. So there aren't like little idiosyncrasies in the physical activity literature. Now, having said that, there obviously is a variety of rigor within those studies, but you can't get away from the idea that these are all very consistent. Dose has not been very specifically evaluated, but most studies have looked at physical exercise over 12 weeks and used 3 times per week with about 45 minutes per session as a benchmark. So the issue is, as I talked about early on, how in the world do you get people who are bone tired to think about exercising? And I've had lots of conversations with people who have said, you know, here I'm telling you I can't barely walk across the room, and you're telling me to go exercise 3 times a week, 45 minutes a time. So I don't actually say that, but I would like to present to you some strategies for actually helping patients get to be more active. And one of the things I want to start with is this study that was actually done in Korea and published in Cancer in 2015. So it was a very interesting study looking at patients who had finished treatment, and they were stage 1 to 3, both breast and colorectal patients. Stage 4 patients were excluded. But they randomized patients to get a recommendation alone for exercise from their providers, a recommendation from their providers for exercise with an exercise package, which included a DVD, a pedometer for tracking their steps, an exercise diary, and a 15-minute education session about how to use the package. Or usual care alone, which they didn't get any kind of recommendation for anything. The outcome of this study was the amount of exercise, and the mean age of the population was 52. And what they found was in the control group, they actually, over this 4 weeks, decreased activity by 39 minutes a week, which I think is quite a bit. The recommendation-only group pretty much stayed the same, improving about 1 minute per week, and the recommendation plus package week got a whopping 48 minutes per week added on. And so for me, what this study emphasizes, and is true in my clinical experience, that it takes more than talking to patients and giving them a recommendation about a behavior change, whether it be exercise or diet or anything else, but we have to give them a plan and make sure that they have the resources to carry it out. And so some of the things that I do is to find out what patients are regularly doing right now, and kind of in a broad way. So, you know, how much do they sit at a desk? How much do they sit in their house, you know, knitting, watching TV, whatever the case may be? How far do they have to walk to go to various places in their house? Do they have stairs? So that you get kind of a sense of what their level of activity is on a given day. And then certainly, and then plan an activity of choice with an implementation plan. What do you think you might like to do? and what do you have resources to do and access to. So whether they have a treadmill in their house or a bike or a walking path nearby, and then thinking about when would they do this, when does it fit into their life, how are they going to approach it, and then really talking about motivators. And I think this is really important. So if they have a bike, let's say, and they could think about either taking a bike ride a couple of days a week with their grandkids or kids or a significant other and make it a social time as well as meeting their activity requirement. I personally use this on myself because I am not motivated to do physical exercise just naturally. So I have an elliptical, and I actually buy DVD series of TV shows that I cannot get, or things on HBO, etc. And I can only allow myself to watch them if I'm on my elliptical. And it works quite well as a motivator, especially if you get into a mystery kind of series and you can't wait for the next episode. You're on that elliptical a lot more than what you actually thought you would. So the ultimate aim is 3 to 4 times per week, 30 to 45 minutes. And again, I don't talk to patients about that really up front. That is a goal because I don't want to overwhelm people in thinking that, the way I feel right now, there's no way I'm doing that. And so it's really a progressive strategy to get people just started, just get a taste. And it's amazing how much that helps then when they have achievable goals that they can then get the next step. So baby steps and overwhelming goals aren't achievable. The last thing though that I think is very important that's often overlooked, no matter what the behavior is and no matter what the symptom management issue is a follow-up phone call. So that would be somewhere around 3 to 4 weeks, I think, after the discussion of the implementation plan. So it's long enough for people to really try to start the behavior, but it's not too long that if they're having trouble, they've already given up and are so frustrated they don't even want to talk to you about it. And studies that have actually incorporated this into their intervention to try to help people be successful with behaviors have found that actually one phone call, like you don't have to put this on your list of things to do for the next year to call patients once a month or anything like that. One phone call that is well-timed can make the whole difference with somebody being successful in a behavior and not. So psychoeducational strategies are also something that's been studied and found to be helpful. These kinds of things are providing psychosocial support, mostly around coping strategies, educating patients about what to expect in terms of fatigue, and then providing them with some ideas about how to manage the balance of energy and fatigue they experience. So this is called energy conservation. Work's been done in this area by Andrea Barsovic, and she defines this as a deliberate plan management of personal energy to prevent depletion of energy. And it involves setting priorities, letting go of things that really don't have to be done, scheduling important activities around energy peaks, even though cancer-related fatigue is quite persistent and an unusual tiredness. There are times during the day that people tend to feel better than other times, and so helping people arrange their activities around those times is important. Scheduling rest periods, not necessarily napping, and then overall pacing life's demands and joys. So this was a study that Dr. Barsovic did with 369 patients randomized to an energy conservation activity management group versus a healthy diet education group, so very nice control group. She included people with various types of cancer. 28% had stage 3-4, and the intervention was delivered over 3 phone calls only over a 5-week period. There was some homework that totaled about 75 minutes over that entire 5-week period that included self-monitoring and journaling, and then they looked at 3 different measures of fatigue. And this study did something that's very important. So the group was learning energy conservation strategies, and she actually looked to see was the intervention group actually using energy conservation strategies. And indeed they were, and so the intervention was doing what it was supposed to. And it's something that I think we sort of take for granted. I think in our research sometimes that we think that the intervention group is actually receiving and doing what we are intending. And that's not always the case. And checking that is really important when you're trying to figure out mechanisms of how something is helpful. So in that study then, all 3 fatigue measures demonstrated significantly lower fatigue levels in the group getting the energy conservation. The study was replicated in a smaller sample size, but also a heterogeneous population, a little bit more advanced patients. They did not use an active control but a usual care control and didn't measure uptake, but still found that the energy conservation group did improve significantly on fatigue. So I think this data set is pretty consistent and worth having some conversations with patients about. Cognitive behavioral therapy is also mentioned in all 4 clinical guidelines, 3 of which call it effective. Cognitive behavioral therapy is a multifaceted approach that is well established in psychological treatment of depression and mood disorders. With regard to fatigue, it's actually helping people think about fatigue differently, look at stress and behavioral strategies such as relaxation, sleep hygiene, coping information, and even sometimes adding energy conservation techniques. And so as I've reviewed this area of research, I say that most studies have a kitchen sink approach. And what I mean by that is that oftentimes when somebody says I'm doing evaluating cognitive behavioral therapy for fatigue, they will put 5, 6, 7 things together. It may be a little bit of relaxation, it may be some sleep management, it may be some imagery, maybe some yoga, maybe some physical activity, and there's really no rhyme or reason as to what they're including and why. And interestingly, a lot of these studies do incorporate either physical activity or energy conservation. The ones that do tend to be positive. The ones that don't tend to be negative. And so it's hard for me to look at that group of evidence and say that it's actually the cognitive behavioral therapy that's having the impact on fatigue and not the physical activity or the energy conservation. So I think this is one area where I would not necessarily employ cognitive behavior therapy in and of itself for patients with fatigue. I don't think the data's there, and I think it could be potentially a waste of time. So I did add a couple slides that aren't in here, but I want to just tell you about it because I think it's really important. So yoga is another potentially useful treatment for fatigue that actually has been in several of the guidelines as something that needs more data. But there have been 3 studies that have been done looking at Iyengar yoga, restorative yoga, and then a non-specified type of yoga. These studies have included anywhere from 31 to 200 patients, and all of the studies improved fatigue in the yoga arm. Some of them with very good control arms. And the studies have been very clear that the amount of improvement people get is tied to the number of classes that they go to. So I think there is some sort of dose effect in the yoga studies. But importantly, yoga again has been matched to that mechanism of cancer-related fatigue. Studies done by Julie Bauer at UCLA and even Lorenzo Cohen at MD Anderson have shown that after yoga, pro-inflammatory cytokines are down, and also that cortisol slope is steeper. The HbA function seems to be a bit better. So as you know, when we get up in the morning, our cortisol is the highest, and over the day, we have this decline till it's the lowest at night, so we can actually go to sleep because melatonin and cortisol are opposite. So what happens with fatigue is that patients tend to not be so high in the morning and not so low at night. So they kind of have this flatter slope. And Lorenzo Cohen's work has shown that after yoga, the slope is nice and steep. And so I think that some of those, so I think that despite the fact that guidelines say that there needs to be more data for yoga, I think that the number of positive studies that there are and that matched mechanism, in my mind, moves it up a bit in the evidence criteria. So to finish up, a lack of clear physiology, I think, does hamper the discovery of effective interventions. And for many strategies, the jury's still out, but I think for other strategies, they're ready, I think, for us to incorporate them into practice. For advanced patients, I think a short trial of steroids is a reasonable thing. Physical activity discussions and planning are needed, and if we could figure out a way to move these into our cancer care early on so that patients aren't bone tired by the time we start talking about this, the better off they will be, both from a physical standpoint but also an emotional standpoint. Principles of energy conservation are helpful, and I think American ginseng also may be a reasonable thing to try. And I think some of those mind and body interventions like yoga, like Tai Chi and Qigong, which has some really good research coming out now, they incorporate sort of this meditation and deep relaxation sort of mechanism. And I think that I'm also doing some work in hypnosis in both cancer-related fatigue and body image and hot flashes, again, inducing a deep relaxation. And I think that level of relaxation and meditation does something to the HPA axis, and if both inflammation and HPA dysregulation are causative in fatigue, I think they have a little bit of something unique to offer, but we have much more research to do to show that mechanism and to really help people identify timing and dose so that people know how to really use their resources appropriately. So that's what I wanted to share with you.